Okay. We are going to have a wonderful, wonderful Create Your Best Life webinar today. We're so excited. Welcome. If you haven't been here before, my name is Brenda Helget. I'm Executive Director of A Time to Heal Cancer Foundation. And I'd like to begin with a few announcements before we get started. So for those of you who don't know, we're now offering continuing education credit for attending these events, which is very exciting. And this applies specifically to the medical professionals who are joining us today. And I know you guys can all read, but I have to read these things, so bear with me. And we're very happy to and proud to announce this activity is being jointly provided by Nebraska Methodist College Professional Development and A Time to Heal Cancer Foundation. Nebraska Methodist College Professional Development is providing continuing education for today's program. So for those of you who need to, please type your first and last name in the chat box so we can mark you as attended. Please attend the entire presentation. No partial credit will be awarded. Please complete the evaluation that will be emailed to you after the event. You will have 7 days to complete this evaluation. Once your evaluation is complete, your certificate will be issued to your professional development accountant, and you will receive an email with a link to access it. If you have any questions, please contact Nebraska Methodist College Professional Development at pd@methodistcollege.edu, and I will be putting some information in the chat box in a little bit. So we want this event to be interactive, so please feel free to come off mute to ask your questions. You can also do so throughout the discussion or at the end during our Q&A. You can also ask your questions in the chat box, and I will moderate that during our discussion. And if you're not asking a question, of course, I've got everybody muted, so don't come off mute unless you want to ask a question so we can avoid the disruptions. Thank you. Also wanted to let you know, obviously, we are recording this event. You can choose to be off video if that would make you more comfortable, but we do welcome anyone to share their video if you would like. So, and again, we are recording right now. So I want to go ahead and, here's the rest of that we're missing. If you want, grab that PD at methodistcollege.edu if you need that continuing education credit. And the reason you're getting this credit is thanks to our wonderful, wonderful friends, Nebraska Cancer Specialists. They sponsor each one of our Create Your Best Life events, including the session today. If you want to learn more about them, please do so. nebraskacancer.com. Okay, I'm going to go ahead and stop sharing my screen. And I'm going to introduce you to Dr. Sean Figy. Sean Figy is an assistant professor of surgery and reconstructive microsurgeon at the University of Nebraska Medical Center, UNMC. He graduated from Siena College and attended medical school at the University of Toledo College of Medicine. He completed his integrated plastic surgery residency at the University of Massachusetts Medical School. And after residency, Dr. Figy completed a fellowship in reconstructive microsurgery and complex reconstruction at the Ohio State University, the Buckeyes, right? Since joining the faculty at the University of Nebraska, Dr. Figy has been instrumental in the development of the Nebraska Medicine Lymphedema Program, which has been identified as the Lymphedema Cancer Center of Excellence by the Lymphatic Education and Research Network. What I'm also going to tell you is that Dr. Figy was a speaker at our conference of 400 attendees back in May. And this was a very, very popular session with very high evaluation marks. So we really this is why we wanted to bring him back so quickly. I also want to let you know we have nearly 70 people signed up for this session, all the way from North Platte, Nebraska to Sacramento, California, someone from Anchorage, Alaska, Jacksonville, Florida, and Mount Sinai, New York, and everywhere in between. So welcome to everyone, and welcome to Dr. Figy.
Thank you for that aggressively over-complimentary introduction. Somewhat undeserved. I'm just a simple As my North Platte folk will say, I'm just a simple country doctor, just doing what I can to help people out. So thank you for having me back. Lymphedema is definitely one of my um, places of passion to work within. So I'm glad I'm able to talk. Um, Today we're going to talk about lymphedema and what are the things. So I always like to give a little bit of a roadmap in terms of what are we going to talk about, where are we going, what are our proposed goals. So I want to be able to talk about some of the basic pathophysiology of secondary lymphedema. And the reason why we need to talk about pathophysiology is because without understanding why we get lymphedema, it's hard to understand how to fix it or how to treat it. We want to talk about some of the risk factors associated with lymphedema, and we also want to talk about some of the basic types of surgical management. And when I say basic types of surgical management, it's not really super basic. It is somewhat complicated, but we're going to try to bring it to a point where we can talk about what types of options there are and what kind of candidates they may be candidates for. Why is this important? I think y'all know this. Being a cancer-based organization, y'all see this more frequently than we should. About 1 in 5 persons who have breast cancer and who are treated for breast cancer will develop lymphedema in their lifetime. That's a lot of people. That's 20% of cancer patients, breast cancer patients, which if you think about lymphedema as a complication of treatment, that's a 20% complication rate. That is absolutely bananas. To give you an indication of like how big of a deal that is, we give antibiotics to patients before we operate on them to reduce the risk of surgical site infection from 4% to 2%. So we're talking like single digit risk factors there. With this, we're talking 20%. So it is a big deal. Of those people that will develop lymphedema, majority of them will develop lymphedema within 12 months of their surgical insult. So within 12 months of treatment, they will develop lymphedema. I see it very frequently actually after radiation. So for persons who are having radiation, it's super common for it to develop in just the few short weeks after the radiation has either started or completed. 90% of persons who will develop lymphedema will develop lymphedema within 3 years. That means there's 10% of people who will develop lymphedema that will develop it outside of that 3-year window. It's about 1% per year after that. So the risk never truly goes away, but it does decrease. So there's that. We also know that lymphedema is not great in terms of quality of life. So we know that it negatively affects quality of life. It has pain associated with decreased mobility. There can be wounds that happen because the lymphatics are so intricately involved with our immune system. There's increased risk for infection because our body can't actually downplay the can't downregulate the inflammatory reactions. So you can get very robust inflammatory responses, infectious responses in extremities. And it's hard to find clothes. You know, sleeves are usually the same size on both sides. And if you've got one arm that's significantly larger than the other, it's hard to find clothes. I have people who, one of their stated goals is they'd like to wear a t-shirt again, or a long sleeve shirt again, or a button down shirt again. And that's really important to them. And that's because they haven't been able to. So it's always very exciting when I see some of my like gentlemen who come in and they have a dress shirt on and they can button their sleeve, or some of my women patients who are able to wear their wedding rings again, and that's very exciting for them. But difficulty finding clothing, difficulty wearing the things that you want to wear is a significant impact on your quality of life. We also know that it's expensive. So lymphedema, and I bring this up for insurance companies because when you talk to insurance companies, you have to talk their language. And their language is not in patient care or patient outcomes. Their language is in money. Insurance companies inherently live in a financially related world. So we talk about what the cost of lymphedema is from a financial standpoint. We know that the existence of lymphedema in breast cancer patients increases the cost significantly, between $10,000 and $14,000 per year per patient. So that's extremely expensive. And the increases are not just in lymphedema costs. It's not just in trips to the therapists and garments. It's in cancer-related costs. It's in non-cancer related. It's in medications. It's in things that you wouldn't necessarily associate with lymphedema, but the existence of lymphedema exacerbates the costs in all realms of cancer care.
Dr. Figgy, quick
Yeah,
question.
yeah.
Does the number of lymph nodes removed increase the risk of lymphedema?
Oh, you are just getting ahead of the game. We are going to go through that in a bit, but you are right there with me. Um, we also note that there's an increase in admission rate, and an admission is very damaging to a person's life. They're taking time out of their life to now be admitted to the hospital. So in terms of how can this impact a person's experience um, through cancer, it's pretty damaging. When we talk about lymphedema, there's two major categories of lymphedema. And we're going to primarily focus on secondary lymphedema, but I would be remiss if I didn't talk at least a little bit about what primary lymphedema is, because lymphedema is one of those diagnoses that actually has multiple causes, and those causes affect how we treat things. So it kind of be like saying you have cancer, but then not differentiating what type of cancer it is. There's different treatments for different cancers for different reasons because they have different pathologies. Same thing with lymphedema. Lymphedema has different causes, so you have different treatments for the different things. Primary lymphedema is a lymphedema that's caused by nothing but the lymphatics. So we do not know what, it cannot be contributed to any other medical cause. Because of that, we've largely differentiated the diagnosis of primary lymphedema based on age of diagnosis. And these numbers are largely arbitrary, interestingly enough. So congenital lymphedema is something that happens between birth and 1 year. Lymphedema praecox is before the age of 35, and lymphedema tarda is after the age of 35. Kind of just briefly, primary lymphedema, the common story that we get is usually women. And they're like, my leg just started to swell. I don't remember any injury. I have no reason for it. My leg just swelled and then went back down to normal, but then it's now continued to get worse. So it's usually someone right around puberty, high school age is where it starts, and then really gets worse during college years. Primary lymphedema is really quite uncommon, although I do see a larger percentage of it here in Nebraska than I did when I was in Ohio, which is neither here nor there. The most common cause of lymphedema, however, is secondary lymphedema, and that is the complication of cancer treatment. That is us. We are the ones causing that. We as the cancer surgeons are the ones that are doing that to patients, and it's part of their cancer treatment. So it's largely a necessary portion of the treatment process, but the ramifications of that are pretty significant. So the most common cause of secondary lymphedema or lymphedema caused by something else is surgeons, and that's in developed nations. In developing nations, it's actually infective. There is a worm that can infect lymph nodes, and those can cause the obstruction. So that's called filariasis, and that's most common in developed nations where they're not doing a lot of lymph node surgeries. Lymphedema is really just excess fluid. So people think that it's excess swelling, and I argue that it's not swelling, it's fluid. Because if you say it's swelling, then a person that has no swelling doesn't have lymphedema, and we know that's not true. We know that you can have lymphedema without swelling, and it presents usually as ache, stretch, pain, discomfort. Lymphedema is the excess fluid that's caused by an obstruction. So when you disrupt the lymphatic system, or you have a lymphatic system that doesn't work, the fluid pools into the extremity or into the location. This pro-inflammatory fluid, this fluid that's left there, is not kind to tissue. It causes a robust inflammatory response, a lot of scarring that can happen. And then that causes the lymphatics to become smaller and less effective. So then you get more fluid pooling, which means you get more inflammation. And then you get smaller lymphatics. So you get more fluid pooling, more inflammation. So it becomes this chronic and progressive disease, which people progress at different rates. So there are some people that will progress very, very quickly. And there are some people that will take 30, 40 years to progress, because everyone, as it turns out, is different. So as such, they progress through lymphedema differently. The way I like to think of it is fluid traffic. we all know arteries and veins. We all know federal interstates, right? Interstates are federally funded. They get all the money. They get all the fanfare. They get named after dead presidents. So when you have an obstruction in an artery or a vein, you know, and people are like, "Oh, well, that's an arterial insufficient, or that's a venous blockage." That's not a question of like, if that gets blocked, it's a bad thing. Lymphatics are like the state routes. They are largely more plentiful. There's more of them. They're smaller. They carry just as much traffic. And there's also back roads around it. So if you block an intersection of a state route, you can usually find a back road to get around. So you don't have that traffic buildup. If you take out enough intersections, you'll eventually stop finding back roads to get by that intersection, and you'll start to get traffic. So it's this fluid traffic model that really helps me understand the pathophysiology of why do we get lymphedema, why do we get the symptoms that we get, and it also helps me kind of figure out what to do about it. Now, the other fun thing to note about this fluid traffic process, this chronic inflammatory process, it's not just fluid that becomes the problems. That fluid being pro-inflammatory then causes the fat in the extremity to get scarred and to get bigger. So it's a fibrofatty hypertrophy, which is huge words for saying big fat scar. And that's why we get big arms that don't go back down to normal. As our disease progresses, that inflammatory process causes that arm to get scarred and that fat to get bigger, and it causes it to get woody and thick, and it can never go back down to the same size that it was before. So that's a disease progression. When we talk about disease progression, there are several ways to stage the disease process. This is the Cheng pathway. There's also the International Society of Lymphology. They are pretty similar with the exception where stage 2 and 3 are kind of merged in ISL. Stage 1 is where the limb swells but goes to normal. Stage 4 is skin changes. It doesn't really change in size because it's already so big. It's very thick and woody. And stage 2 and 3, I differentiate based on what's the predominance of disease. Is it predominantly a fluid disease where you're still having a lot of fluctuation in size? Or is it predominantly a solid disease where that lymphedema has been around for so long or has caused so much damage that that skin and fat is now thickened? It's that fibrofatty disease. This helps us understand what type of surgery and treatment you'll be best suited for, because the different surgeries we have tell us, or the different surgeries we have treat different things. Fluid-based surgery or physiologic surgery does not address solid component, and solid component surgery does not address the fluid process. So we have to oftentimes do multiple things in order to treat things because it's different. They treat different things, if that makes sense. When we're talking about disease, or when we're talking about the workup, so if you come into my clinic, these are the things that I care about. I care about, when did it start? You know, how long after treatment did it start? Has it been getting better? Has it been getting worse? What have you tried for therapy? What works for you? Are you using your garments? Are you using pumps? How often are you seeing your lymphedema therapist? What makes it better? What makes it worse? And then what have you had for lymph nodes removed? What have you had for radiation? Where did they radiate? And then have you had chemotherapy as well? All these things are really important for me to understand what your risk factors were, and what we can do. In terms of physical exam, I'm going to be looking at skin changes. I'm going to be looking at whether I can pinch the skin on the top of your hand or the top of your toe. That's the Kaposi stemmer sign. If your skin is very thick from fluid, we're not going to be able to pinch that. We want to know what it's going to, and we want to know whether it's pitting or not. So that physical exam pitting is how we can differentiate between stage 2 and stage 3. That tells us our solid versus liquid component. And these are the skin changes we can see. So this is a stage 4 lymphedema patient. You can see this kind of papillomatosis where they've got these little kind of papilla, these little nodules on their skin. That is from that chronic inflammation that can happen. This is a stage 4 disease process. When we talk about pitting, If anybody goes to see somebody that says they always have 2+ pitting edema, please give them this slide, because 2+ pitting edema, I find amongst healthcare professionals that have not been trained in lymphedema, is just our go-to number. We're like, 2+ pitting. And that's not true. Pitting is actually something that can be graded. And I think, at least in the medical world, this is something that in medical school we were not well taught. I think the nurses are typically taught a little bit better on this finding. So I don't usually have the same issues with the nurses as I do with like my co-surgeons. But we're working to change that. So no pitting is 0, and then 4+ is severe, and this can be differentiated based on depth as well as time to refill. So if you think about it, if you have a lot of fluid, it's going to be deeper. If you have a lot of solid, it's going to take a lot more time for that fluid to pass through. So the more severe disease tends to have slower refill times and deeper pits. When we look at the differential diagnosis, if you come into me for lymphedema, I'm going to work you up for everything else, because I want to make sure that it's lymphedema. Because if I try to treat you for lymphedema and it's not lymphedema, that's a silly mistake to make. And we want to make sure that we're treating the disease process instead of missing the diagnosis. So this is an important concept that we try to do as well, to make sure that we're hitting the right marks. When we talk about lymphedema and lipedema, they are very different. So I often get people coming in with a lot of confusion about what lipedema is versus what lymphedema is. And lipedema also causes large extremities, but it's typically in more defined areas. So they have very large ankles, but their feet are spared. They have a pretibial fat pad. So there's a large collection of fat right in front of their tibia, or their hips are quite wide. So that's this very standard distribution of fat that happens in lipedema, whereas lymphedema is fluid mediated. It gets very confusing because you can have both in the same person, but they're treated differently as well. So it's not super common to have lipedema and lymphedema without lymph node injury or lymph node surgery. And interestingly enough, lymphedema therapy does give some benefit to persons with lipedema because it's an inflammatory fat process. So when you can remove some of that inflammatory process, when you can do some of that lymphatic massage, it does actually help a little bit with lipedema, but it doesn't help a lot. And then the surgeries we do for lymphedema do not help lipedema. May-Thurner is a venous disease as well as venous insufficiency. We always look for venous issues because we want to make sure that we're not also missing traffic patterns in the interstates. We want to make sure that we know where our traffic patterns are, because if we're going back to that traffic model, if we have traffic in the lymphatics and we're trying to put the lymphatic fluid into a vein that also has traffic, we're not going to actually fix the traffic. So we need to make sure that we're identifying what our traffic flows are so we know where we can put fluid. You may end up having some diagnostic tests because now we can actually diagnose lymphedema. Back in the day, we only had tape measures. And you were diagnosed with lymphedema based on tape measures. And it was dunking your extremity into a vat of water and looking at volume displacement. So historically, measuring volumes has either been messy and wet or partially inaccurate, but that was our way of diagnosing lymphedema. So we looked for a 10% change compared to the contralateral side. So we'd measure your arm, we'd measure the other side, and we would do a formula to figure out the volume of your extremity. And then if it was 10% more than the other side, we could diagnose you with lymphedema. That neglects those early stage disease patients. That neglects the people that don't have a lot of swelling. So we were getting later diagnoses than we potentially could. But also there is some physiologic difference that exists normally. So if you're right-hand dominant, your right arm is going to be bigger than your left arm just because you use it more. And that's where that 10% came in. Since then, we now have better studies that are more diagnostic because they can actually identify some bigger issues. So we have lymphoscintigraphy. This is a nuclear study. We'll go through these as well. Bioimpedance testing, which is non-invasive and can be done in the office. And we also look at different imaging modalities in terms of like indocyanine and green and MRIs that we can do. So when it comes to limb volume measurement, this is still our gold standard because it's transferable. This can be done I won't say easily because it's definitely a skill set. So this can be done pretty consistently amongst your own office. So you can see differences over time, but consistency is really key because if you measure different spots at different times, you're going to get different measurements. I mean, just look at your arm, the difference between your wrist and your elbow is very different. And just a few centimeters different can change that number pretty significantly. So we measure at different landmarks, typically 4 centimeter marks along the extremity, and then we can do a standing cone deformity or a standing cone volumetric cone formula to calculate the volume. So, but consistency is key because if you're getting different measurement spots, you're going to have different volumes. So while it is transferable, it can be inconsistent. We also have what's called pyrometry now. So pyrometry uses LED and light receivers to actually measure the limb in a lot more detail than we had before. The problem with this is they're expensive. They're $28,000 a machine. And it does require somebody to actually use it. We do have one of these at the Med Center. Do I want more? Yes. But that's because I love toys and I love to get new toys for the hospital. As it turns out, I'm a big fan of buying things. They don't love it because that costs money. So, but these are really great because it makes it so much quicker for our lymphedema therapists to get volumetric measurements of an extremity. This takes, a few seconds to swing the pyrometer through, and then it's calculated by a computer. Whereas when you have to do measurements, it can be a 10 to 15 minute process to get the measurements and then put those into your calculator and then to get the data. So these are nice, they're quick and accurate. I want more of them. So if anybody knows anyone I can buy these off of on the black market, I'm happy to, because I will get them from anywhere. They're great. Lymphoscintigraphy is it's a useful study. It's not as useful as it once was. This is more useful in staging. Where do we do the lymph node removal from more than is this a lymphedema issue? It can show us dermal backflow. So it can show us fluid that's stuck in the tissue. It doesn't give great detail, however, on the size of the lymphatics, the location of the lymphatics. It gives us a yes or a no. It's very much a binary study. Yes, you have lymphatics that exist. Yes, you have lymph nodes. No, you don't have lymph nodes. Yes, you have dermal backflow. No, you don't. It also can give you some time frames as how long it takes that fluid to transit. It can take a long time to do this test though, because you're getting these x-rays every 30 minutes for 4 hours. So it's not the most fun study in the world because they do have to poke a needle between your toes or your fingers, and that hurts. It can take a long time and it doesn't give you really excellent exposure. So for the pain and time, it's not as helpful as one might hope in terms of figuring out what you need for surgery or treatment. This is the image we get. You can see it's not the most beautiful. I mean, it could be artwork for a wall, but it would just remind me of sadness. So I don't want that. But you can see that here we have lymph nodes that are highlighting, but this down here, this bright white in the limb, that is dermal backflow. So that means that the fluid that is in the leg doesn't have channels to go through. There's no roadways for that lymphatic fluid to traverse through, so it goes through the skin. It's like if you're on a hike, but you can't find a trail, you just find a way through the woods. It's what's going on there. Whereas if you've got a hike with a trail, you're going to go through that. That's what the lymphatic channels are. Everything goes through those channels because it's the easiest pathway. When you don't have lymphatic channels, it goes through the skin and it presents with this dermal backflow. MRI lymphangiography is a better study, in my opinion, for workup of lymphedema, both from a surgical and etiological, meaning what causes it standpoint. So if a person comes to me with swelling that they don't understand, I'll typically get an MRL initially as a diagnostic study to see what they have in terms of lymphatics, because not only does it give me flow rates, it tells me like how quickly things are moving, but it also gives me location of lymphatics, locations of lymph nodes. It gives me information about veins. It can also tell me how much of this swelling is solid fat versus fluid edema. But it is expensive. So insurance companies, again, don't love it. So we sometimes have to go through some things before they'll approve it. It also is a longer study. It's very similar in time as to the lymphoscintigraphy. It does also require some shots, some injections either between the toes or between the fingers. They don't feel good. I will not even lie about that. I'm not going to pretend to lie about that. It's not a nice study. I usually get cussed at when I have people come back. But then we make up. It's fine. They just aren't a fan for that. They have to get it off their chest, and that's fine with me. I will take that brunt. Okay, this is the imaging that we get. You can see these lymphatic channels are much easier to identify. It can also show you the veins. So over here, this double arrow, that's the nice venous system, but you can see these beautiful lymphatic channels that exist, and they can do a 3D rendering where you can actually kind of turn the extremity in space, and you can see where it is in relation to the skin, in relation to the bones, muscles. So you can have that as a study. This is my personal favorite study because I get to do it and I get to see exactly with my own eyes, and you see it too, as to where the lymphatic channels are. So we again use a needle to inject some dye into the hand. I do like to think I do a better injection than the radiologists, though, so it doesn't hurt as badly. It might also be that I have my physician assistant put some numbing medicine into the hand before I inject, so it doesn't hurt as badly, but we'll leave that up for y'all to debate. This gives us real-time data. We actually watch the flow of the lymphatics over time. So you and I will use a special camera that, again, goes back to my desire to have the hospital buy me presents. This is a nice special camera that specifically picks up indocyanine green. And that's what we inject into the hand. And it glows bright green. So you can see the flow of lymphatics. You can see the channels that it's going through. You can see the size of the channels. You can see the function of the channels. And you can see the areas where the channels stop. You can see where they back up into the skin. They cause swelling. The problem with this is we can't use this dye in persons with an iodine allergy. And also, we can't use this if the skin is deeper than 1.5 to 2 centimeters thick. So for persons who have very severe disease where they have a very large limb, we either need to have to go to lymphedema therapy first, which they should have already done, or we need to debulk and do liposuction first to bring that skin down so we can find those lymphatics because they can't be found otherwise. This is what it looks like, and you can see this is the actual picture. This is the lymphatic picture. You can see the flow of the lymphatic, these lines, and then you see these little squiggles as it brighten, like spreads out. That is a classic example of a lymphatic channel terminating in lymphatic disease. So you can see this linear channel, and it's really cool when you watch this too, because you can see the flow and you can see them peristalt. You can see the muscles of the lymphatics kind of moving the fluid along, and then you see it spread into the skin. So while it's not a great, it's actually a good sign to have that. I can treat that pretty easily with reasonable success. But it is kind of a fascinating thing to watch. And you'll get to see that because so you know exactly where we're going to go for disease process or for treatment. But it also helps people visualize what's going on. So I think it does help with a bit of understanding as well. Conservative therapy is the most important part of lymphedema care. And I know I saw a few of my lymphedema therapists that I work with on this call, and they are my like real MVPs when it comes to the care team. If we do not have lymphedema therapy, we have nothing. Surgery does not supplant therapy. Surgery and therapy work together to give the best outcomes. And that's how it has to be. We have to work multidisciplinarily because my lymphedema therapists are incredible and they know so many things and they do things so much better than I do when it comes to wraps and lymphedema massage and education. And I am a surgeon, and that's something that they don't do. So we work together really, really well, and we kind of have to for the success. But lymphedema therapy can be really largely broken into two major, or CDT, complete or complex decongestant therapy, depending on which book or person you're talking to. That C stands for a different thing. I've heard it both from different therapists around different parts of the country. There's two phases to that. There's reductive and then there's maintenance. Reductive phase, it should be technical component daily. Um, is that the reality? No. It's not the reality because we have one, too few lymphedema therapists, and two, an insurance industry that doesn't understand how real life works. So this is where they'll put like, oh, you get 10 therapy sessions per year, which is not how things work in lymphedema, right? That'd be like saying to a person with high blood pressure, like, yes, we know you have high blood pressure every day for the rest of your life, but you only get treatment 3 months a year. So use your 3 months wisely. It's just like that's not at all the reality. Um, but it's typically supposed to be daily with massage, lymphatic massage, and manipulative therapy, bandaging. There's also things like reduction kits that can be useful that use Velcro. My favorite part about the Velcro reduction kits is people will come and say that they don't work because they just fall off, which is actually the sign that they're working so well because you put them on tight and then they reduce and then they fall off because they worked. So you have to retighten them. So that's the fun fact about the reduction kits. Once you've been reduced as much as possible, then we get to a maintenance phase. And this is where we have garments coming in, whether that's gauntlets or sleeves, different components of padding. And this is where you work with your lymphedema therapist really closely to make sure you have the right size, the right kits, and also they get replaced. Because like shoes, you need to replace them as they get used. They lose some of their stretch component. So the MLD is the sequential manipulations and massage techniques that are used to guide fluid out of the extremity. There's also some like vibration therapies that work by helping stimulate the lymphatics to work. So there's a whole like host of modalities that work for people, and it's really just trying to figure out what works best for you. But we do that with the guidance of our lymphedema therapists, who are the real pros when it comes to like manual lymphatic drainage and CDT. When we go into the surgical
Dr.
world,
Figy, I'm sorry to interrupt, but do you have any tips for those folks? Remember, way out maybe in Alaska or North Platte, Nebraska, and they need to find a therapist. What
yeah,
are some things to look for? I noticed Wendy Buchholz wrote a great note. Please note that occupational therapists can also be certified lymphedema therapists. But do you
yes,
have
sorry.
any other tips?
I didn't mean to say just physical therapy, and if I did, I apologize. Occupational therapy and physical therapy both can go through lymphedema therapy certifications. When we look for uh, who to go to for lymphedema, there are several certifying bodies that do additional coursework in lymphedema. And I think as long as you find a person who has done some work in lymphedema that you trust, those are two very important components to how we work, or how to find a lymphedema therapist. Um,
Is it possible for someone to perhaps if there's something available on, the interwebs, YouTube, etcetera, a certified lymphedema therapist may be showing you different techniques in lieu of, I don't have somebody here in town. Is that
yeah,
helpful? And if you guys know of anybody, if you recommend anything, please put it in the chat to share as well.
absolutely. I take a lot of guidance from my lymphedema therapists, and I come from a part of the country that doesn't have as many rural and frontier areas. So I will be honest with you, I'm learning a lot about how to work with people who have lesser access to close by resources. I'm from Massachusetts, and our idea of rural is you have to drive 15 minutes to the grocery store. So like we are a very different universe than when I'm out in North Platte. Um, like very different universe. When I have people driving to come see me from like 3 hours away because North Platte, like it is a very different universe that I'm working on figuring out.
I would
Um,
also recommend or remind everyone that this is being recorded and you'll have it available so you can go back and look at Dr. Figgy's slides, especially when it comes in relation to, I'm going to mangle the lymphography.
Yeah.
Some of those, maybe the machines you kind of want to be
Yep.
looking for that people have available, and you may have to drive to get to those places,
Hmm.
perhaps. But I really appreciate you, as I am a cancer survivor myself, knowing kind of what to ask and in terms
Yeah.
of what we're looking for. So, ladies, it would be similar, I'm guessing, to those of us with dense breasts that especially need the 3D mammography, right? It's just better and easier for our providers to have that technology, and sometimes it takes a while for that technology to trickle down to the outer regions, to the rural areas.
Yeah, no, and I think that when it comes to some of our lymphedema therapists will do or not some, all of them do some degree of um, teaching on self massage. So there are some techniques that you can learn to do at home. So you may not have to come in as much, and you can do those as part of your maintenance. Um, and it's partially going to be learning those techniques for long-term maintenance. I think one of the things that I hear frequently about lymphedema therapy is that they say it doesn't work, or lymphedema therapy doesn't work. And the reality is lymphedema therapy is not a cure, it's a treatment. It's an imperative treatment. But if you don't maintain the lymphedema therapy, if you don't maintain the garments, if you don't maintain the pumps that you're using, you'll have recurrence of the volume and the symptoms. So when people come to me and say, "Oh, well, I went to lymphedema therapy and my arm got smaller, but then it came right back when I stopped," I think, yeah, yes. Then my answer is yes, it did. Because if you stop the maintenance, um, you don't continue with the benefit, if that makes sense. So it's really important. And as Wendy said, you can get lymphedema really in any part of the body. It's really areas that have poor outflow. So we see this in persons who have very large tummies that kind of fold over. That would be more obesity related lymphedema. That's an outflow obstruction. In the legs, we get it from abdominal surgery because all the lymph nodes for our legs come through our abdomen. So if you have abdominal surgery and the lymph nodes are interacted with in the abdomen, you can get swelling in the legs from that standpoint. So there's lots of reasons that can happen in lots of different locations, but working with your lymphedema therapist is a way to kind of understand the different tips and tricks as to how to treat that. When we get into the surgical side, which is definitely my area of expertise in comparison to the therapeutic side, although we are working on creating a LANA course for surgeons to be done at our annual meeting. So hopefully I'll be able to go through that um, so that I can have a better idea. Not that I will ever espouse myself to be a lymphedema therapist, but at least I can better understand what my lymphedema therapists are doing and kind of talk the talk and do my raps better in the operating room so I don't get called in disappointing turns about like, well, this rap was terrible, Sean. Well, I did my best. Hopefully they haven't been too bad for you, Wendy. um, so excisional surgeries are the solid component. So when we talked about the solid versus the fluid component of disease, the solid component procedures are excisional in nature. And those are liposuction, direct excisions where we just cut and close, and then Charles procedures. And Charles procedures can be modified in many different ways. So what is liposuction? That's a great question. Let's go through it. Liposuction is also called SAPL. So you'll hear SAPL or suction assisted protein lipectomy. We've sometimes just have to change words in order for insurance companies to not think that this is a cosmetic surgery, right? Because liposuction is what we do if we want to get a beach body, not like a normal sized arm, right? Wrong. Liposuction is removal of fat and protein through small incisions, but with long cannulas. So it's not a minimally invasive surgery by any sense of the imagination. It's actually very invasive. It's minimally incisive. So we use small incisions and essentially remove as much fat and tissue as we can from that superficial plane as we possibly can. This is useful for solid component disease. It does not work great with fluid dominant, but if you have a large solid component, a large fiber fatty disease, we can significantly reduce the volume of your extremity with liposuction. It does not address skin. So you will have wrinkly skin. And I might be the only plastic surgeon in the history of the universe to say openly and proudly, I love wrinkles. I do. They are my favorite. Because when I see wrinkles, that means the arm is not inflated. So wrinkles are my absolute favorite thing to see on an extremity. It is my favorite thing. So this is useful for persons who have a solid component disease. The big takeaway point you should take from liposuction is that the surgery is the easy part of the treatment. It is exhausting. It is hard work. I skip arm day that day when I'm doing liposuction because it's a lot of like back and forth and a lot of pushing through tissue. But that's the easy part, because the hard part is maintenance afterwards. So there's drains in place. We use compression garments. I'll be putting wraps on your arm in the operating room. You'll be seeing your lymphedema therapist every other day to get rewrapped and massaged in the postoperative period in order to keep that arm small. And then once the drains come out, we do double compression garments for another like 6 weeks after that. And then you go to single compression. And if we've not done anything to address the fluid component, that single compression is the rest of your life. So it's important to note that the maintenance is important afterwards. The scarring that we create is to keep that arm small, but maintenance of that extremity and maintenance of that size is imperative. So compression garments are a component for essentially the rest of your life. But it allows you to get into clothing again. It allows your arm to be less heavy because we're removing a lot of volume. And for my patients who don't have lymphedema, or my people that don't have lymphedema, it's like, think about carrying around a gallon of milk every day at all times for the rest of your life. That is essentially the volume that we're taking out from some of these arms. So it may not seem heavy initially, but as you keep that gallon of milk in your hand for the rest of your life, it's very, very heavy. So if we can remove volume from the arm, it does improve quality by decreasing the weight of the extremity. I use arm a lot because this is a breast cancer group that I'm speaking to, or a cancer group in general, and it's all cancers, but like it's breast cancer is the most common, and I see mostly breast cancer, so I apologize if I defer to arm for most everything. That is where I live the majority of my life. But I do see extremities. I've seen legs, arms, head and neck, scrotum, vulva. So I've seen all the different, a lot of different body parts, breasts, for lymphatic disease. So it can be anywhere, but extremities are where majority of us live in the surgical world. Okay. In terms of excisions, this is a direct excision where we make an incision on one side on the other and we just reduce volume. This is really great for persons who have developed what are called lobules. So the lymphedema exists in an area and then kind of pulls that tissue down so it ends up with a stalk or an umbilicus that holds it there. But these patients have a near 100% risk of complication from surgery. And I say you will have a complication. The type of complication I'm not sure of yet, but you will have something go wrong. The proposed benefit has to outweigh the risks. So that's what we look at when it comes to excisional procedures. So if the proposed benefit, meaning they're able to actually ambulate even with a wound, that is a better benefit than living with a beach ball between their legs, because they've got a massive lymphatic lobule hanging off their thigh. But again, they have a huge complication rate because lymphedema tissue doesn't heal as well. This is why we try to keep our incisions very small with lymphatic surgery and lymphatic treatment, because it's less things to heal. But they have a very high complication rate. But the patients who need this are so happy when they're done. And I tell them, you're going to have a complication, but I'm going to be with you the entire time through it. We're going to get through it together. And that's where we're going to be. So we go into it with our eyes wide open. A Charles procedure is a radical excision of tissue above the fascia with grafting afterwards, most commonly done in lower extremities. So this is for persons who have extreme lower extremity lymphedema primarily, and just severe quality of life impact. This is not a surgery I do lightly, and this is not a surgery that I convince people to do. This is a surgery that my patients have to convince me to do. because that is how impactful this can be. I need them to come to me and be like, this, I need you to do this. Come on now. Like, quality of life is terrible. Conservative management's not working. I'm willing to go through the risk of the surgery because it is a big surgery. This picture makes it look really pleasant. The reality is it's not. The reality is it's graphic. The reality is it is a hard recovery, but when you recover, these people are so happy because they were not able to wear pants. They were not able to go on hikes. They're now able to walk. So persons who are candidates for Charles procedures that are like this, it is, again, a huge surgery. It's a big deal, but once they are healed, they are so happy. But again, this is a surgery you've got to convince me to do. Because I'm not gonna, if you're waffling as to whether you want to do this or not, you're not ready for it. Because it is a lot. The physiologic surgeries are the surgeries that I do, that I'm fellowship trained in. Charles procedures, liposuction, excisions, those can be done by essentially any plastic surgeon, anywhere. Those are all things that can be done by a plastic surgeon in any location in any part of the country that does not have to have fellowship training in super microsurgery. When we get to physiologic surgeries, this is where persons may want to have done a micro fellowship before they'll do this. And this is up to the surgeon. Like our fellows from the University of Nebraska do enough of these with me where if they feel comfortable in practice to offer this, they can, because they do a ton. They do these. I do a ton of these. I do like 75 to 100 of these a year. So our fellows get well trained in this, but not every plastic surgeon is going to be one that offers this. So this is where you have to find a specialized surgeon. When we talk about physiologic surgeries, these are surgeries that focus on fluid. So these are the ones that focus on the root cause of lymphedema, the fluid pooling. So those are basically two different categories of surgery. One is a lymphovenous bypass or lymphovenous anastomosis, and these are either therapeutic or prophylactic. And we also have vascularized lymph node transplants. So these are lymph node transplants. A lymphovenous anastomosis is a therapeutic intervention, meaning a person has lymphedema and we need to treat said lymphedema. This is what we do all of our dye studies for, to identify lymphatic channels and areas of disease. Because what we do is we connect a lymphatic to a vein. Because if we go back to our traffic pattern analogy of what lymphedema is, if we have traffic in the state routes, we have traffic in the lymphatics. If we take that lymphatic and connect it to a vein, now there's a place for that traffic to go. There's a way for that traffic to get into the interstates so that it no longer exists in the arm. Okay? For people to be a candidate for this, they have to have those roadways still existing. So typically it's going to be earlier stage patients, stage 0, stage 1, and stage 2. There are patients in stage 3 and 4 that we can find lymphatic channels on. They are typically less successful, but they still do have some benefits in terms of overall inflammatory process. But the persons that benefit most from this are stage 0, 1, and 2 disease, which is why it's so important that we have earlier diagnosis and earlier treatment for lymphedema, because as things progress, they become harder to treat. This is a 3 to 6 hour surgery. It is day surgery. You go home same day. The incisions are about that big. So they're quite small. We do multiple incisions in the extremity. They are not done typically in the armpit. We do them down on the hand, forearm, and upper arm. So we do them where the disease exists as opposed to where the disease started. So we are not back where the lymph nodes were taken out from. And people typically start to feel better pretty quickly because, as you can imagine, as soon as you start to alleviate traffic patterns get better. So people start to feel better pretty quickly. There's no narcotics associated with the surgery. It's small skin incisions that we use a long-acting local anesthetic for, so you go home with Tylenol and Motrin. Post-operatively, I ask that you do not wear a compression sleeve, because what I don't want is this movement. I don't want rubbing over the incisions, because the suture that we're using is smaller than a strand of hair. And the needles that we're using are 2.5 millimeters in length. So they're very, very small. We can only see these sutures under a microscope. The entire surgery is done under a microscope. So I don't want those sutures being torn. Compression is completely okay. Wraps are completely okay. Pumps are completely okay. But really avoiding that shear force on those incisions is really important so we don't tear those incisions open. These are actually not new. These first started in 1977, but they were not super prevalent or super prominent because we didn't have really great microscopy. Our microscopes have gotten better. So since our microscopes have gotten better, more people are able to do them. But we know that these work. There was a study done by O'Brien in 1977 that described this procedure, and then he showed his long-term results in 1990. So that's 13 years. And he showed continued improvement over those 13 years. So I love this study because it's an old study. So it's not like this is a newer investigational surgery. We've been doing this forever. It also shows that over 13 years, there's continued benefit. The problem with our studies in plastic surgery is our volumes are low. We don't have a lot of patients. Plastic surgeons, I mean, I am one of them and I love my people, but we are not the most collaborative with each other when it comes to research. So we don't typically pool all of our data together. So we don't have large studies. And because these are relatively uncommon surgeries, we don't have any randomized controlled trials on them either. So insurance companies tend to fight us on those things. There's a lot of issues with that, in my opinion, but this is not a new surgery. It's been around for quite some time. This is the procedure itself. So you can see that these are very small. That lymphatic looks huge. Being mindful that those boxes are each a millimeter in size. That's one of the biggest lymphatics I've seen. And so I was like, that's a massive one. I need a picture because that is so big. That is a millimeter in diameter. So those sutures are very small. That lymphatic is big for lymphatics, but not huge in general, comparatively. Right? So does it work though? But yes, it does. It does work. We even have studies from more recently where we had 100 consecutive patients. Upper extremities, again, do better. This is why we care about stage and getting people in early. 61% improvement on average for stage 1 and 2 disease. So these are fluid dominant, and that makes sense. Whereas stage 3 and 4, the volume is not that great improvement because that's mostly solid component. But we do know that most people do better. 96% of patients feel better. 74% have a decrease in volume. So we can do some good things. I want to make it clear, though, that this is not a cure. Most people will still require some degree of treatment, compression, or therapy afterwards. So my stage 0 disease patients, my stage 1 disease patients, those are the patients I think we can potentially get out of compression garments every day. But once you get past stage 1, I think that you're probably going to end up with some degree of compression, just in general. But we can improve quality of life pretty significantly, which is great. And again, I love wrinkles. I really do. I can't get over how much I love wrinkles. It's just my favorite. We also know that upper extremities work better than lower extremities, and that's a gravity component. So lower extremities just in general do worse from a wound healing standpoint, from a venous insufficiency standpoint. So lower extremities don't do nearly as well. We can still make some benefit. We can still do our best to help, but they are not as successful as upper extremities. We also know that we are seeing, it's not just in our brains, it's not just in our minds, we have actual pathology data. We're able to look at skin samples both before and after a lymphovenous bypass, and we see actual physical markers of decreased inflammation. We see decreased CD4 plus cells, which means nothing to almost anyone except for the pathologists. But those are pro-inflammatory cells. So we see these markers of inflammation that all get better when we do lymphovenous bypass. So we know that we're doing something to decrease that inflammatory process. Lymph node transplants are a little bit more aggressive. And when I say a little bit more aggressive, I mean a lot more aggressive. Whereas lymphovenous bypass is day surgery and you go home same day, lymph node transplant means you get to come stay with me in the hospital for a few days. We have to take lymph nodes from one part of your body and then transplant them to the area that has the disease. So where is your swelling? That's where we put the lymph nodes. This is a big surgery. You have to be in the hospital with us. We have to monitor those blood supplies that we put together. The other thing to note is that the effects of this lymph node transplant really aren't going to be seen for months to years, because the function of these is that we increase lymphatic growth from the new lymph nodes that we put in there. And that lymphatic growth will then act like a sponge and it'll collect the fluid. But it takes time for that to happen. So the impact of this is less quick. You still have good benefits though. So in general, I like to do lymphovenous bypass first because people do better from a recovery standpoint, and they do better from an immediacy of response standpoint. So I can get people better faster with lymph venous bypass, and it's less invasive. There's also the risk of developing lymphedema in the area that you take the lymph nodes from. And that's usually a non-starter for people. That's usually something like, well, if you're going to give me lymphedema in my other arm or my other leg, I do not want to be part of that. And I get that. I would not want that either. One of the things that I do that's a little bit different from some of the other places is I prefer an intra-abdominal lymph node source. So my preference is to take lymph nodes from inside your abdomen, from your what's called mesentery. It's where the lymph nodes are in the small bowel as it attaches to the aorta. There's this like sling of tissue that's full of lymph nodes. So many lymph nodes that I can take 4, 5, 6, 7, 10, and you won't notice that they're gone because lymphedema of the small bowel doesn't exist. So I can take lymph nodes from there and transplant those, and we know that has good outcomes. It does put you at increased risk of hernia, but hernia is easier to fix than lymphedema of a donor site. So that's my rationale. Different lymphedema surgeons have different rationales. I was lucky enough to train at Ohio State with Roman Skracki, who pioneered the intra-abdominal donor site. So I tend to be a disciple of Skracki, and I tend to prefer that in general. And if you ever meet him, he might be the nicest person that's ever existed. Like disturbingly kind and talented. I'm like, that's not fair. You get to be one. You get to be one. Okay. What we're doing now, and this is a little bit more cutting edge, is we're trying to prevent lymphedema because the best way to treat lymphedema is to prevent it. I would love to put myself out of a job from a therapeutic standpoint. Lymphedema is terrible. People don't love it. I don't love the fact that people have lymphedema, and I would love to try to prevent it. So things that we are doing. One, the cancer surgeons are doing a better job of not removing lymph nodes if they don't have to. That's the first thing. If we can decrease the insult, that's great. We know that a risk factor, one of the risk factors for lymphedema is greater than 10 lymph nodes. There's your number, Brenda. Greater than 10 lymph nodes. We also know that radiation and chemotherapy are each risk factors. If you have all 3 of those risk factors, you have about a 40% risk of lymphedema. 40. So not great, but 10 is the number of lymph nodes. One of the things that we're doing now is what's called an immediate lymphatic reconstruction. So in persons who need to have lymph node dissections, especially with breast cancer, torso-based cancers. So vulva, vulvar cancers, breast cancers, torso-based tumors for melanomas. At the time of lymph node dissection, what we're doing is we're taking those lymphatics from the extremities. We are mapping those specific lymphatics, so not from the area of tumor, from the place that will be affected by the treatment. And we are connecting those lymphatics to veins at the time of dissection. That way, we know we're putting construction sites up on those intersections, but we're putting an on-ramp in at the same time. So we're creating a pathway for that fluid to flow so it never gets stuck, it never builds up. This is not a silver bullet. What it does is it reduces risk from about 40% to about 4%. So pretty gosh darn good. That 4% is sort of creeping up in the literature a little bit. There's a study out of Memorial Sloan Kettering that's coming out. Their rate is about 12%, which is down from 25 to 30% of lymphedema rates in the persons who are not getting immediate lymphatic reconstruction. Our personal data at the Med Center here in Nebraska, we just pulled it last year for our 1-year lymphedema data. We are at 5% lymphedema, which we should be much higher, which is great that we're doing as well. So I'm really proud of that. We've got a great team here. And we now have 4 surgeons that are doing immediate lymphatic reconstruction. So it's not just me, which is great because that means I get a night off every now and again. Because these are usually afternoon and late night surgeries. So that is where we're at with trying to prevent lymphedema because we want to put ourselves out of a job. That's our goal. Same thing with burn surgeons, always trying to put ourselves out of jobs. This is what it looks like. It's very small. Again, these are 1 millimeter. And there's a lot of data to support this. Again, I love reading through the policies and the insurance company policies because they do these mental gymnastics to be like, all these studies, you'll read the paragraphs of their justifications, it'll be like, in all these studies, it showed benefit. And then to the bottom, be like, all the studies were not huge and they weren't randomized controlled. So we're going to deny it based on investigational. I'm like, if you have a preponderance of data and you have all of this information, I don't understand. And it's been around since the 70s. We should probably have a discussion about how you just don't want to pay for it now. And there's a discussion about that. We have made pretty significant improvements, however, in insurance coverage. So Blue Cross Blue Shield of New England has an actual policy for lymphatic surgery. And because that policy exists now, we can use that to push other insurance companies to tell them what to do. I will say we've had pretty reasonable success with insurance coverage in Nebraska. So that's been good. But it is not it's not a slam dunk. I have a templated lymphovenous bypass appeal letter for when it gets denied. So I just have to put in patient-specific information. I have all the data cited because that's how frequently I have to use it. I have that ready to go. But we have a pretty good success on appeal to get these done as well, which is good. So the takeaways and the things I want people to really understand is that lymphedema is a team sport. It is not something that one person or one team can do. It's a team sport. So I need my lymphedema therapist, and I hope my lymphedema therapists think that they need me, but I don't know if we're there yet. I will get there. I'll convince Wendy that I'm wonderful. Wendy's one of my lymphedema therapists I work with extensively at Methodist, and she is pretty awesome. I'm not, I don't say so myself. Prevention is key. So how can we prevent lymphedema therapy? And Susan is one of my people out of Great Plains, and she crushes life too. Sorry, she just mentioned, she's popped up in the chat. We've got awesome humans. Surgery does not supplant therapy, and therapy can be augmented by surgery. So we kind of have to work together. And often multiple modalities are required because physiologic surgery does not fix solid and solid surgery does not fix physiologic. We oftentimes have to do multiple. So it's a journey. There's lots of different paths that can be taken, and we have to just kind of individualize everything to everyone, but it's an absolute team sport. So with that, I will take any questions.
Anybody want to ask Dr. Figy? Now is your chance. And Dr. Figy, thank you for being an advocate for all of us.
Yeah,
It's
Susan and
deeply
Wendy, did I miss
appreciated.
anything?
Here's Wendy's got one in the chat. Is immediate lymphatic reconstruction planned only for patients who know they will have ALND prior to surgery?
So at the Med Center, what we have done is we don't do frozen sections anymore on lymph nodes. So we don't have any unplanned lymph node dissections. So for a person who's having a sentinel node biopsy or a targeted node dissection, a targeted node is a little bit separate. Targeted nodes, we will sample. I will be on standby for those. So those are, we plan for them to be a lymph node dissection. And if they don't have to be a lymph node dissection, awesome, love it. That's the best news. But we don't really have any unplanned lymph node dissections anymore. That's been a big change in practice here at the Med Center, at least, because if we are going to do a lymph node dissection, we want immediate lymphatic reconstruction. It's become our standard of care. Stacy, SLL. I'm blanking on this abbreviation.
Oh, I thank God, because I was about to ask, what is SLL? Do you want to answer Rita's question and then go back to Stacy's?
Yeah, so compression stockings help prevent venous insufficiency because they don't cause the stretch on the veins. I don't do this for SLL. That no. For lymphomas, this is not so much treatment for lymphomas. For compression stockings, they'll prevent, yes. So we do have some components of compression that will help with venous insufficiency. You'll see a lot of surgeons wear compression stockings because it also helps our feet feel better when we've been on our feet for 14 hours a day. Oh no, Miranda, I'm sorry. Yes, we can do them. So we can do additional surgery. So we can do therapeutic lymphovenous bypass as well as lymph node transplants. So for all of my patients, I always counsel them that if you're part of that 4% or 5%, and you have swelling, and we say there's expected swelling for the first 2 months afterwards, then we will have you come back in and we'll go through the therapeutic pathways and try to tee up for therapeutic lymphovenous bypass in the extremity or lymph node transplants if necessary. I do wear compression stockings on occasion. I'm also a terrible patient for several reasons, one of which is I'm a physician and therefore, by definition, a bad patient. If you ever talk to any physician or nurse, you'll know that people that work in healthcare are bad patients. We just are. So I'm not great about that.
And Stephanie would like to ask a question.
Yeah, I'm going to answer Wendy and then we'll get to Stephanie.
Perfect.
For the LVA for breast lymphedema, I don't typically do that. And the reason why is because I worry about putting a lymphatic connection from an area there where there was tumor or existing tumor and putting that into a venous system. So I worry about potentially making a pathway for cancer to spread to the blood system by putting in a lymphovenous bypass. So I don't typically do that. I have, however, seen some benefit in lymphedema of breast with fat grafting. And part of that is because radiation disease is usually associated with it. And I think that a lot of breast lymphedema is actually mostly related to the radiation that they get. So when I see persons with breast lymphedema, one, I can do some direct excisions from that if necessary. But a lot of it, I also have to figure out the differentiation between radiation disease and lymphatic disease. I think you can treat both with some fat grafting, because fat grafting, when we take fat from the other parts of the body with liposuction, we also take adipose-derived stem cells. So we're taking stem cells from the other areas that have not been radiated, and we're restoring those into the area that has been radiated. Radiation destroys stem cells, and we can take those stem cells, and then they will differentiate into different blood vessels and lymphatic vessels and help treat the condition of that skin so it becomes less woody and less painful. So I've seen some incredible results with fat grafting. We've also been able to do lymph node transplants into breasts. So you can do lymph nodes into breasts where you take omentums and you can take an omentum and put that into a breast, and that can help treat some lymphedema of that area as well. But I like to try fat grafting first because it's, again, day surgery. Patients tolerate that surgery better than they would a lymph node transplant. Stephanie.
Hey, it's Jake Wiesen. Can you hear me?
Lindsay.
Oh, hey, huge Sean Figy fan, and everyday compression stocking wearer.
Better surgeon than I am.
Hey, you mentioned like you guys don't do any unplanned axillary dissections. So historically, if you can't locate a sentinel lymph node, the plan was go ahead and do an axillary dissection, which is unplanned at that time. At this point, would you say if you can't find the sentinel node, is it time to stop the surgery and do a planned axillary dissection later?
We haven't really had that come up with us yet. I think that for our group out here, they probably would.
Oh, sorry.
I see
Sorry
how
about
it is,
that.
Brenda. Muting me.
I was trying to get myself.
That hasn't come up here in the 4 years that we've been doing medial lymphatic reconstruction. But my impression is they'd probably call me and see if one of us is available. But we're pretty strongly in the medial lymphatic reconstruction camp here, which is, I think, good because the risks of that surgery are pretty low. So we haven't had that situation come up. I cannot speak for our breast surgeons here on that. But we haven't had an unplanned lymph node dissection in quite some time. Also, Jake Wiesen is one of my favorite surgeons. He works at Great Plains Health, and he has a very shiny head and is a very pleasant human. So I enjoy working with him as much as I can. Let's see. Let's go to our questions. Lee, I have lymphedema. I'm sorry about the lymphedema. Can you get drainage in your stomach on the right side too? Right arm, right side. So yes, when you have lymphedema therapy, one of the things that happens in the way lymphedema therapy partially works is it tries to push fluid into areas where the lymph node basins are functional. So you can get some swelling that comes out of the extremity and into the torso. So that is a possibility of some things that can happen. If you've had radiation, I find that there's a lot of confusion between what happens with radiation and lymphedema. So people come in, and I've had many, many consults come in where they have like chest wall lymphedema, and it's really just radiation fibrosis, because that tightening that can happen with the radiation causes it to feel stiff and causes it to feel full because it doesn't move, it doesn't have compliance. So it can happen with that as well. So you can get some fullness on that right side because of where the fluids are draining to. You can also get it from radiation. It can be a lot of things. Oh, truncal lymphedema, post lymph node dissection, and inflammatory breast cancer. So, inflammatory breast cancer is one of my like most feared and hated adversaries, because you have the whole shebang. You get modified radical mastectomy, you get chemotherapy, you get radiation. So, inflammatory breast cancer is not a pleasant disease process by any sense of the imagination. I do think that, again, some of that lymphedema that comes from the truncal component is from radiation. So we have to differentiate that out. Those are patients that I really like doing fat grafting on. But also with inflammatory breast cancer, the data says you should not be doing reconstruction for 2 years. So we wait 2 years after completion of treatment to do any sort of reconstruction on the torso for inflammatory breast cancer. We can do things on the arm, but not on the torso, because we don't want to miss recurrence. So we wait 2 years, and that's data supported for T4D, which are inflammatory breast cancer patients. We wait 2 years for any treatment for that. Any
I
other
think
questions?
yes, I think we've kinda come toward the end of our time here, and it didn't look like there was any more questions, unless there's somebody who wants to get one last minute question in. I think we will let everyone get on with the rest of their Saturday.
Yeah, happy
Anybody?
Saturday, y'all.
Yes, and Dr. Fee, thank you so much. Again, as a survivor myself, this has been very informative. I really did not understand the full risk when I was diagnosed 8 years ago, and I had 19 nodes removed, so I feel very lucky that it has not happened to me yet. So I'm very appreciative of all the information. Everyone, again, this recording will be available on YouTube for you to access at any time. And I hope you have a wonderful, wonderful Saturday. And thanks again to you, Dr. Figgy. We really appreciate you so much.
Well, I hope you all have a great day. And I think we're doing better with education now. And I think we've gotten so much better with cancer treatment that now we have to care more about longevity and quality of life. So I think actually the more recent um, thought process on quality of life is truly a testament to the fact that we're getting better at treating cancers. So people are living longer. So we have to like worry about how are they going to feel in 20 years. Because the reality is most patients are going to get there these days, which is fantastic. So I think it's a real luxury that we're actually able to start talking about how are we experiencing post-cancer life. So I'm hopeful for that, but now we got work to do. Let's do it.
Absolutely. And thanks once again to our sponsors, Nebraska Cancer Specialists, for enabling us to have CE available and to have this wonderful webinar from Dr. Figgy. Everyone have a great rest of your weekend. Thank you so much.